Hello, OB friends. Today we are going to start with Chapter 13, the Anatomy and Physiology of Pregnancy. We are going to get right and start talking about some important terms. We're going to talk about gravity. Not about gravity, things falling from the sky, not about things like apples falling from a tree. We are going to talk about the gravid uterus. So the first word is gravida. Gravida is referring to the gravid uterus, so a woman who is pregnant. This refers to the number of times a woman has been pregnant, regardless of the outcome, the pregnancy outcome. And this refers to the current pregnancy that is also counted in this number. The next term is gravity, so pregnancy. It just refers to pregnancy. Multigravida is a woman who has had 2 or more pregnancies, or she is pregnant for at least the second time. A multipara is a woman who has been pregnant she's had more than one pregnancy, resulting in a viable offspring. And a nulla gravida is a woman who has never conceived a child. We talked about, or we will talk about, on the next slide, we'll talk about parity. So let's move on there. Parity is the number of pregnancies reaching a viable gestational age, and that's including live births, stillbirths. Really, the number of fetuses doesn't determine the parity. So a twin pregnancy carried to a viability is counted as one para. Okay, so she's para 1, and she could have 2 living children. All right. Nullipara is a woman who has not completed pregnancy with a fetus or fetuses who have reached the stage of fetal viability. Right now, it's really a little bit controversial what the stage of viability is. So 22 to 24 weeks is considered viability for a fetus. Primipara is a woman who has completed 1 pregnancy with a fetus or fetuses who have reached 20 weeks gestation. And a multipara is a woman who has completed 2 or more pregnancies to 20 weeks gestation or more. So these important terms, and please refer to Blackboard because I have put some information on there from the NIH that will help you just break this down a little bit clearer. But a preterm is a pregnancy that has reached 20 weeks gestation but ends before the completion of 37 weeks. And just remember that to reach the completion of 37 weeks, you have to get to 37 and 6 days gestation. Late preterm pregnancy is that has reached between 34 and 0 and 36 and 6. So remember, we have to complete that whole 36th week. Early term pregnancy that is reached between 37 and 0 and 38 and 6. Full term is a pregnancy that is reached between 39 weeks, 39 and 0 and 40 and 6. And late term, 41 and 0 and 41 and 6. And a post-term baby is a pregnancy that has reached between 42 and 0 and beyond gestation. The important reason that you need to know that we're breaking down these gestational ages is because babies grow, and they need to grow in the uterus, and there's a lot of things that go on and continue to grow while they're in the utero. So it's important that they can get in there and bake as long as they can. So there's certain things that are continuing to grow as they move along in gestational age. So it's certain things that aren't as what's the word I'm looking for? Well, there's certain things that aren't as pronounced and is not as I can't even think what I want to say right now. I apologize. But they need to be in there as long as they can. So some things aren't, like for instance, a baby that's early term is not going to be a great eater or a great breastfeeder as a baby that's full term. For a baby that's a late preterm is even going to be a less great feeder than a baby that's early term. So that suck swallow is not as great as early term or full term. So we watch those feeding habits and those cues and things. So there's certain milestones that each baby will get to as they reach gestational ages. Now, we have already talked about pregnancy tests and that human chorionic gonadotropin, that HCG, and how that's the earliest biochemical marker for pregnancy, and how the production begins as early as the day of implantation. And that can be detected in maternal serum or urine as soon as 7 to 8 days before the expected menses. And these tests are available everywhere. You can find them at the dollar store, at drugstores, at grocery stores. But just keep in mind that the production of that BHCG, that is a subunit of the HCG, and that can be recognized as early as the day of implantation and can be detected in maternal serum or urine as early as that 7 to 8 days. The levels usually double approximately every 2 days for the first 4 weeks of pregnancy, and the level of HCG rises until it peaks at about 60 to 70 days after conception, and then it declines to its lowest level at about 100 to 130 days, and that's when the placenta becomes the primary source of estrogen and progesterone, which we all know is that the wonderful hormones of pregnancy. The signs of pregnancy, we have 3 of them: the presumptive, the probable, and the positive. And the presumptive are those signs and changes felt by the woman. And these are the ones that she's going to talk about. So amenorrhea, so she's not getting her period. She's super tired. She's having those breast changes that we discussed. Her breasts are starting to swell. With the fluid increase and things like that all of the changes that are going on in her body. The probable changes, and these are the changes that are observed by an examiner. So the Hagar sign, ballottement, positive pregnancy tests, that would be a serum test done in the clinic or hospital. And the positive signs. These are the signs that are attributed only to the presence of the fetus. So hearing fetal heart tones, visualizing the fetus by ultrasound, actually palpating fetal movements. So Hagar sign. The Hagar sign is the softening of the lower uterine segment, and this is classified as a probable sign of pregnancy. And this is usually present during the 2nd and 3rd months of pregnancy and is palpated during a bimanual examination. Ballottement also is a probable sign, and this is the movability of a floating object and like a fetal head. So when we're doing a sterovaginal exam, we can actually touch the baby's head and feel it bounce up and down against our fingers as we're checking. This is, when the baby's tapped or pushed, it moves away and then returns to the touch of the examiner's hand. There's also something called Chadwick's sign, and Chadwick's sign is a visible something that we actually see. So it's the cervix, and because the cervix is very vascular during pregnancy, it looks violet bluish in color. It's because it's a mucous membrane, and we can see that about the 4th week of pregnancy, and it's just because of that increased vascularity during pregnancy that it turns that color. We're going to talk a lot about adaptations to pregnancy, And there's a lot of things, but the first thing that we'll talk about is what the adaptations that our body goes through. And the first thing that we'll talk about is the uterus. And our uterus is dealing with a lot of high levels of estrogen and progesterone. And they stimulate a huge surge of uterine growth in the first trimester. And therefore, there's a great increase in vascularity and dilation of blood vessels. Sometimes some hyperplasia because there's a production of new muscle fibers, maybe some fibroblastic tissue, a little hypertrophy, enlargement of pre-existing muscle fibers, and some fibroblastic tissue. So there's a lot going on in that growing uterus. Our uterus starts off the size of our fist and then begins to grow very quickly. So that leads us into some contractility issues. Soon after, maybe the 4th month or so, uterine contractions can be felt through the abdominal wall, often referred as Braxton Hicks contractions. They're very irregular, they're painless, and they occur intermittently throughout pregnancy. Some women complain that they're annoying, but they usually cease with walking or exercise and hydration. Hydration is very important during pregnancy, regardless if you're having Braxton Hicks contractions or not. It's important that our pregnant patients remain hydrated. Hydrated is going to keep contractions away. Or hydration, I'm sorry. A dehydrated patient can go into premature labor. A dehydrated patient is at a higher risk for a UTI. There's a lot of things that, just maintaining hydration can fend off. So, Braxton Hicks are often mistaken for true labor. However, they really don't increase with intensity or duration, and they don't change the cervical dilatation. So, conversely, premature labor contractions can be mistaken for Braxton Hicks contractions, which lead to a delay in seeking treatment. So you always want to make sure when we're talking about contractions that we make sure that we ask our patients, are the contractions regular? Are they painful? Are you able to walk and talk through them? So really talking to your patient about the regularity, the time, the duration of the contractions. So that tells us, are they Braxton Hicks or are they real contractions? Uteroplacental blood flow. Gotta slow my roll. Placental perfusion really depends on maternal flow to the uterus. So thinking about blood flow, and in pregnancy it increases rapidly as this uterus increases in size. Although the uterine blood flow increases tenfold, the fetal placental unit grows even more rapidly. So consequently, more O2 is extracted from the uterine blood during the latter part of pregnancy. In a normal term pregnancy, usually 1/6 of the normal maternal blood volume is within the uterine vascular system. So just in the uterus, 1/6 of the total maternal blood volume. So, that's a lot of blood. The rate of blood flow through the uterus averages about 450 mLs per minute. And at term, the oxygen consumption of the gravid uterus increases to meet fetal needs. So, all of that, everything baby needs is, funneling through that uterus. And the placenta. I told you that placenta is the powerhouse of everything that baby needs, and it all goes through the uterus. So 3 factors known to decrease uterine blood flow are low maternal artery pressure, contractions, and maternal supine position, which we talked about. Well, we didn't talk about, but we will talk about. And these are important things that you'll want to know. So remember those 3 factors that are known to decrease uterine blood flow: low maternal artery pressure, contractions, and maternal supine position. being on their back when they're pregnant, that they could be on the vena cava or the aorta, and that makes them that could make them dizzy, and it could cut off a little bit of oxygen to the baby. So we want them on their left side, preferably on their left side, because that makes the flow a little bit better, but on their right side if they're more comfortable. So we might hear something called a uterine souffle or a bruit. Sounds like a little bit of a rushing or a blowing sound. It's the maternal blood flowing throughout the uterine arteries to the placenta, and it's a real nice synchronous sound with the maternal pulse. Sometimes makes people a little bit nervous, but it's nothing to be nervous about. We also have something called the Phoenix souffle, also very synchronous with the fetal heart rate, and this is the fetal blood coursing through the umbilical cord, and you hear it up near the cord. May also be heard as well as the fetus's actual heartbeat. So those are just two things that we can actually hear with a stethoscope or a Doppler. Some of the cervical changes that go on with mom with these adaptations to pregnancy in a normal unscarred cervix. So there's a couple things that happen with some cervixes. If, for instance, if mom has an abnormal pap prior to pregnancy, she could have a LEEP procedure, or maybe have biopsy of a cervix. That would be why she would have a scarred cervix. But in a normal unscarred cervix, softening of that cervical tip could be observed about the beginning of the 6th week of pregnancy. And this is a probable sign of pregnancy, and it's called the Goodell sign. And this is brought about by that increase in vascularity. Slight hypertrophy and a little hyperplasia, which is just that increased number of cells. This muscle is very collagen-rich, connective tissue. It starts to become a little bit loose and edematous. It's very highly elastic, and it increases in volume. And the gland is near the external os of the cervix. And it begins to proliferate beneath that stratified squamous epithelial cells. And it gives the cervix a velvety, soft appearance during pregnancy. Really very soft and supple looking. It's very, very friable during pregnancy because of its vascularity, and it can be very easily damaged and can result in slight bleeding after vaginal exams, after intercourse, because of deeper penetration. So we have to make sure that we're educating our parents or our moms and our FOBs also that this can happen, and that we have to tell them it's okay that they have intercourse, and this is a side effect of that vascular cervix. The cervix in a nullipara is nice and round. Lacerations can occur during the birth process, fairly normal, and after delivery the cervix becomes more oval in the horizontal plane of things. Never is nice and round the way it started. So our poor cervix never looks the way that it started out after delivery. Some of the other adaptations to pregnancy, changes that are related to the presence of the fetus. Some of the greatest times that a pregnant mom can feel is that quickening feeling, which is that maternal perception of the feeling of life. And that usually occurs anywhere between the weeks of 16 to 20 weeks of gestation. But it could be felt earlier by our multip moms, so our moms that have had babies before. There's something called lightning, and this is a sensation that sometimes, when we're further along in pregnancy, our babies are way up high, up by the diaphragm, and when those babies begin to move down into the pelvic cavity, the fetal presenting part settles into the pelvis, and it usually occurs about 2 weeks or so before the onset of the labor, especially in our nullips. And the moms are like, oh, I can breathe and I can eat better and I feel like I sleep better. They usually have to pee a lot more, but they just feel like they can breathe a lot better. So that's what lightening is. We talked about Braxton Hicks already, those mild, intermittent, painless uterine contractions that occur during pregnancy. Just remember that these contractions occur more frequently as pregnancy advances, but they don't represent true labor because they're intermittent, they're not painful, they usually go away once mom is hydrated, if she's up moving around, and but they're not making any cervical change. What else are we seeing here? Leukorrhea. Leukorrhea is a white, maybe a slightly gray, mucousy discharge from the cervical canal or the vagina. Has a faint, musty odor. It's normal, physiological, caused by the pathological states of the vagina and the endocervix. If that discharge gets thick, very heavy, has like a fishy, foul odor, that's something you want to talk to the doctor about. We have to counsel our patients to contact their doctor. If it changes in color or anything like that, that's something they have to contact their doctor about. I always tell my patients that they should be wearing cotton underwear. Keep those underwear dry. If the leukorrhea is very, heavy, they can't stay in those wet, moist underwear. They should be changing the pad and keeping themselves dry and clean. So hygiene is a big deal because they're at a higher risk for UTIs. So it's important that they're keeping themselves dry and clean. Goodell's sign, we did talk about that already. So that softening of the cervix, that probable sign of pregnancy, which occurs during about the second month or so. We talked about our friable cervix, which is easily broken. It can refer to that fragile condition of the cervix, especially during pregnancy, because it causes that cervix to bleed easily when touched. When they go into doctor appointments, they don't always get a cervical check. So they're not getting cervical checks until they're further along in pregnancy, probably at least 37 weeks, unless something else is going on, unless they're having premature labor or something of that nature, or bleeding or something like that. So the vagina and the vulva, just to throw those in, hormones start to prepare the vagina for stretching by causing the vaginal the mucosa to really thicken and the connective tissue to loosen. The smooth muscle begins to be a little bit hypertrophic, and the vaginal vault starts to lengthen just to prepare for delivery. We talked about that increased vascularity and how it results in that violet, bluish vaginal mucosa and the cervix, so Chadwick sign, and that can be evident already around the 6th week or so of pregnancy. So really keeping that in mind, I want to let you know that that's not the only thing that starts to happen. I mean, the vaginal vault starts to loosen. Women start to lose some of the rugae in the vagina already, so that begins to start to stretch, getting ready. We have something called relaxin as a hormone, and that starts to loosen up some of the things that we have, and we'll talk about relaxin again a little bit longer down the line. Our breasts start to get ready for labor and delivery as well. So, along with our uterus growth, we have that. Well, let's talk about the uterine. We talked about that already. So our breasts, we have that they start to feel full. They're very sensitive. They start to tingle. They start to feel heavy. And honestly, you start to feel like, oh my gosh, these aren't mine. And that already starts early, in the early weeks of gestation, in response to an increased level of estrogen and progesterone. The nipples and the areola become more pigmented. The secondary pinkish areola develop, extending beyond the primary areola, and the nipples become a little bit more erect, and that's very, very normal. And they do start to become, they hurt a little bit because of that. We do start to get a little, the sebaceous glands start to become a little bit hypertrophic, and this is because they start to become embedded in the primary areola, and this is called the Montgomery tubercles. And you can see them around the nipples because they're a little bit more swollen. And within those tubercles are little sebaceous and sweat glands that start to secrete lubricating and anti-infective substances to help protect the nipples and areola during breastfeeding. Now, you don't actually see those little things secreted, but it happens. So it's pretty amazing. This picture, as we discussed, what I really want to point out, and my goal with this picture, is just to look at the venous network and the darkened areola. And in a picture like this, you can see where her areola was and how the pigmentation started to extend out past the original areola. And really that venous network just started to, take off, and it's showing you how the breast started to swell a little bit, and that network is starting to make more pathways for them to become working breasts. So now we're going to start talking about some of the general body systems and the changes that those are going to go through. So I talked a little bit about that diaphragm and how it starts to become moved up, and it is really displaced upward by the enlarging uterus, but this also starts to displace the heart. The heart is elevated upward and rotated forward just a little bit to the left. So the PMI is shifted upward and laterally about maybe 1 to 1.5 centimeters when pregnant. The changes in the heart size and position and increases in blood volume and cardiac output contribute to some oscillatory changes common in pregnancy. There's some audible splitting. Usually S1, S2, S3 can readily be heard after 20 weeks gestation. More than about 95% of women develop a systolic murmur during pregnancy, and they're more audible over the left sternal border. And these changes are transient, and they disappear in most women shortly after they give birth. So when you're in clinical, you won't hear, unless they had a murmur before pregnancy, you won't hear those. And this is just because of where that heart is displaced to during pregnancy that this happens. The maternal heart rate during pregnancy begins to increase already about week 5 gestation, and it reaches a peak of about 10 to 15 beats per minute over the pre-pregnancy baseline by about 32 weeks gestation, and kind of persists until term, until delivery. Probably around late 3rd trimester, this increased heart rate helps maintain cardiac output because we have a higher cardiac output in pregnancy. Moms may experience palpitations, some cardiac rhythms can be disturbed. She can experience some sinus dysrhythmias, maybe premature atrial contractions, premature ventricular systoles. So, there can be some things that are going on. her, in this, as the slide says, our blood volume and composition increases significantly during pregnancy by approximately 30 to 45%. Cardiac output increases 30 to 50%. We have, pregnancy is considered a hypercoagulable state, and there is a lot going on at this time. Blood pressure, our brachial blood pressure is usually highest when sitting, lowest when lying in the lateral recumbent position, and intermediate when she's supine, except for she has a hypotensive syndrome. So always we want to take her blood pressure in the same arm. So, our documentation is important to make sure that we're following through with that. Make sure that we're using the proper cuff size. During pregnancy, the maternal blood pressure remains the same or decreases slightly, and this is due to that reduced systemic vascular resistance caused primarily by the vasodilator effects of progesterone and some of the prostaglandins and relaxin. Sorry about that. And relaxin is that nice hormone that relaxes some of the things in our body and just relaxes some of those arteries and blood vessels. So we have to watch and always talk to her about getting up slowly, moving slowly when she's getting up, so she's not tipping over on us. The uteroplacental vascular system holds a large percentage of the maternal blood volume, which also contributes to decreased systemic vascular resistance. And this systemic vascular resistance is lowest at, I'd say, between 16 and 30 some weeks. So, and then it gradually increases, and then she gets back to her non-pregnant state right around term. Cardiac output, increases, like the slide says, 30 to 50% over the non-pregnant rate by about 32 weeks of pregnancy. And it declines to about 20 weeks, or 20%, at about 40 weeks gestation. And this elevated carbon dioxide is largely a result of increased stroke volume, or this elevated cardiac output is largely a result of increased stroke volume and heart rate, and occurs in response to increased tissue demands for oxygen. Cardiac output increases with any exertion, such as labor and birth. The plasma volume and total red cell mass are controlled by different mechanisms, and pregnancy provides the most dramatic example of the way in which that can happen. So a healthy mom with a normal size fetus and an average birth weight of about, let's say 6-7 pounds, can increase her plasma volume by about 1,200 mLs, a little under 50% of the average non-pregnant volume for white European women of about 2,600 mLs. So there's a lot going on during pregnancy. Circulation and coag times. Women are 5 to 6 times, they're at a 5 to 6 time chance or risk for thromboembolic disease during pregnancy. The circulation time decreases slightly by week 32 and returns to near normal by term. So there's a great tendency for blood to coagulate during pregnancy because of the increases in various clotting factors. So factor 7, factor 8, factor 4, 5, factor 7, factor 8, factor 9 and 10, I think, and fibrinogen. And it decreases in factors that inhibit coag time. So protein S is important to think about. The tendency, combined with the fact that fibrinolinic activity is depressed during pregnancy and the postpartum period, provides a protective function to decrease the chance of bleeding, but it also makes the woman more vulnerable to thrombosis, especially after a C-section. So that's something to keep in mind when we are taking care of our patients. Respiratory-wise, maternal oxygen requirements increase in response to the acceleration in metabolic rate and need to add to tissue mass in the uterus and breasts, in addition to fetal oxygen requirements and a way to eliminate carbon dioxide. The elevated levels of estrogen help the ligaments in the rib cage to relax, permitting increased chest expansion. And that's where relaxin comes in again too. It helps the ribs to relax a little bit to get more oxygen requirements. The upper respiratory tract becomes more vascular in response to elevated levels of estrogen. The capillaries become more engorged. Edema, hyperemia develop within the nose, pharynx, larynx, trachea, bronchi. This congestion within the tissues of the respiratory tract give rise to several conditions like we discussed. So commonly seen in pregnancy, we'll have mamas that have nasal and sinus stuffiness, epistaxis, which is nosebleeds. They'll have voice changes, marked inflammatory responses. They always seem like they have upper respiratory infections. Their ears always feel full, or they have ear infections, or impaired hearing, earaches, or just a sense of fullness in their ears. So there's always something going on up there. Pulmonary function, respiratory changes in pregnancy are related to the elevation of the diaphragm and changes in the chest wall. So changes in respiratory center result in a lowered threshold for carbon dioxide. And these actions of progesterone and estrogen are presumed to be responsible for the increased sensitivity of the respiratory center to carbon dioxide. So although pulmonary function is not really impaired by pregnancy, diseases of the respiratory tract can be more serious during this time. So one important factor to think about is that we have those increases in oxygen requirements. Some of the, talking about basal body or basal metabolism rate, this is increased during pregnancy. That's really all you have to really think about. And that elevation in basal metabolism rate reflects that increased oxygen demand. And it's because that uterine placental fetal unit and greater oxygen consumption because of increased maternal cardiac work. There's a lot going on. So, in that third trimester, the BMR is increased by 10 to 20% over the non-pregnant state. There's peripheral vasodilation, acceleration of, gland activity that helps dissipate the excess heat resulting from the increased BMR during pregnancy. Our moms get hot and, there's so much going on, and these pregnant women can experience heat intolerance. So it's just some slight exertion they experience by many women early pregnancies. They get dizzy and they feel yucky, and they have, they get fatigued easily, and that can be caused in part by that increased metabolic activity. So just keep that in mind. Acid-base balance, by about the 10th week, there's a decrease in the partial pressure of CO2, and progesterone may be responsible for this increase in that sensitivity of the respiratory center. And that's just because maybe that tidal volume increases and the partial pressure O2 decreases. The base excess or bicarb decreases, pH increases slightly, and these little alterations in acid-base balance indicate that pregnancy is a state of respiratory alkalosis. So you want to, keep that in mind, that pregnancy is a state of respiratory alkalosis. These changes also facilitate the transport of CO2 from the fetus and O2 released from the mom to the fetus. But, there's a lot of anatomic changes in the renal function. We talk about, mom having to pee all the time. So, some functional changes in fluid and electrolyte balance. So just thinking about some of those anatomic changes, there's results from hormonal activity. So estrogen and progesterone, those hormone powerhouses in pregnancy, the pressure from that enlarging uterus and an increased blood volume. Think about what that does to our body, especially the renal system. As early as about the 10th week of pregnancy, those renal pelvis and the ureters start to dilate. The dilation of the ureters is more pronounced above that pelvic rim, and in part because they're compressed between the uterus and that brim. And because of the changes, a larger volume of urine is held in the pelvis and the ureters, and the urine flow is slowed. So that urinary stasis or stagnation has several consequences. That lag time between urine, when the urine is formed and when it reaches the bladder, so that clearance can result in, that's why they're at an increased chance of UTI. And that stagnated urine is an excellent medium for growth of microorganisms. In addition to urine of pregnant women contains more nutrients, including glucose that increases the pH, making that urine more alkaline and making these little pregos higher risk to UTIs. They're at a higher risk for bladder irritability. Of course, they have their nocturia. The urinary frequency and urgency is always there, but commonly reported in early pregnancy and return at term because they're bigger bellies. But and again, when lightning occurs, they have to they're up to the bathroom more often. So in pregnancy, renal function is altered considerably, but that happens because of these changes and caused by hormones and an increase in blood volume and woman's posture, physical activity, and nutritional state. But the kidneys must manage that increased metabolic and circulatory demands with the body as well, and just the excretion of fetal waste products. So there's an increase in the GFR that results in an increased creatinine clearance and a reduction in blood urea nitrogen, so that BUN. And there's also some uric acid levels that we are dealing with. So renal function is most efficient when the woman lies in a lateral recumbent position, least effective when supine. So another reason why we want that mama off her back. Uterus puts pressure on that vena cava and aorta, again, like we talked about, decreases the cardiac output, like we talked about before, and decreases blood flow to the brain and heart at the expense of other organs and the baby. So keep that mama off her back. So fluid and electrolyte balance, selective renal tubular reabsorption really maintains sodium water balances, regardless of changes in dietary intake and losses through sweat, vomit, or diarrhea. About, I'd say, 950 to 1,000 milligrams of sodium is cumulatively retained during pregnancy just to meet the fetal needs, although some maternal serum levels of sodium decreases. The maternal kidneys undergo a significant adaptation by increasing that tubular reabsorption like we talked about. Integumentary system, we have something called melasma or cholasma, also termed as the mask of pregnancy. Melasma is just a blotchy, brownish hyperpigmentation of the skin over the cheeks, nose, sometimes on the forehead, especially in darker complected pregnant women and some women taking oral contraceptives. It's just, I don't know, some people get it, some people don't get it. It's just, and it goes away after delivery. It doesn't magically go away right after delivery. It just fades away. The linea nigra is this pretty little line from, I think it's cute. Some women are like, oh, I just hate it. But it's just a little line that goes from the umbilicus down to the down the belly. Striae gravidarium is just a fancy name for stretch marks. A lot of women are like, well, what can I do to get rid of those? And really, just keep them hydrated. It's not going to get rid of them. Some people are just prone to them. It's what your skin is, and how fast. It's about weight gain, how fast the weight gain is. Some people, just get rid of them easy, and some people don't get rid of them. So it is what it is. Palmar erythema is related primarily to increased estrogen levels, and it's just a red swelling of the palm of the hand. I'm sorry, excuse me. The pruritus or the pup rash, the pruritic uricardal-papules and plaques of pregnancy is one of the most common specific dermatosis in pregnancy. So they're little lesions that usually appear first on the abdomen but can spread to the arms, thighs, back, and buttocks. The pup rash classically appears usually, primips get it quite often and usually appears in the third trimester, but always causes severe itching, isn't associated with poor maternal or fetal outcomes. A lot of times starts as little papules, little fluid-filled papules. Very, very itchy, very bothersome to our poor patients. Sometimes are treated with topicals, Benadryl, things of that nature. So there is something called pruritus gravidarium, which is a mild, usually itchy over the abdomen, very common in pregnancy. But otherwise, some of our moms have issues with carpal tunnel. So carpal tunnel is just some, compression of some nerves that really are very bothersome. More, if someone's working at a computer all day or things like that, but caused by edema that compress the median nerve just beneath the carpal ligament of the wrist, causes some burning or tingling sensation. A lot of moms have a lot of issues at night where it wakes them up. So there's also some moms have compression of pelvic nerves or vascular stasis, and that's caused by some enlargement of the uterus that can result in some sensory changes in the legs. So some dorsolumbar lordosis, and that can cause pain. We talked about lordosis in wellness assessment. So back in the sophomore days, talking about lordosis, and that can cause pain in the back just because of the traction on the nerves or compressed nerve root. And some of these things too, with that large uterus, you can become have some lightheadedness because of how fast you're getting up. So always remind them to get up slowly. So lightheadedness, faintness, syncope, common in pregnancy. Vasomotor instability, so that postural hypotension, even issues with hypoglycemia in pregnancy, and that could be an issue with that lightheadedness and faintness. So hypocalcemia can cause some neuromuscular problems, like muscle cramps or tetany during pregnancy. Musculoskeletal issues. Our mamas have an increased risk of falling due to the shifting center of gravity. So impaired balance. We have joint laxity because of relaxin. That hormone relaxin and progesterone cause some loosening of the ligaments of the pubic symphysis and the sacroiliac joints, and that is to facilitate labor and birth. Usually by 28 to 32 weeks gestation, that symphysis widens from approximately 3 to 4 millimeters to about 7.5 to 8 millimeters, give or take a millimeter. And that separation of the symphysis pubis and that instability of that sacroiliac joint can cause pain and difficulty in walking. And this is why we call our little pregos waddlers. That waddling gait is common because of that. When we have a mom who's a little bit fluffy or obese, or moms who have multi-babies, so a multi-fetal pregnancy tends to increase that pelvic instability. So we have to be very careful with those patients and explain to them how careful they need to be. Appetite intake fluctuates during pregnancy, so morning sickness. Moms could have during pregnancy with or without vomiting, possibly in response to the increased level of HCG, and this alters carbohydrate metabolism. Nausea and vomiting appears anywhere 4 to 6 weeks gestation and usually hopefully subsides by the end of the 3rd month, and severity varies. Sometimes there's cravings, some are non-traditional, so we have something called pica. Pica is the craving of non-food related items. We'll talk a little bit about that. We'll talk a little bit more about pica. What else? Mouth, some gums become hyperanemic, spongy, swollen. They tend to bleed quite easily, and that has a lot to do with estrogen. Estrogen causes some selective non-specific gingivitis, and it's important to make all the scheduled dentist appointments that you have made already, and take really good care of your mouth and teeth. Some women complain of excess saliva or during pregnancy, which can cause the unconscious decrease in swallowing by the woman when she's nauseated, and that can make her want to throw up more. But sometimes eating some starchy foods may help that. There's that upward placement of the stomach because of the baby moving up, and that can increase the risk of hiatal hernia. And some women get we talked about the epulis, and that's that raised little nodule in the gum that bleeds easily, and that could develop around the 3rd month or so, and it often continues to enlarge as pregnancy progresses. It's usually managed by avoiding trauma to the gums, so not brushing it very hard or not flossing it till it bleeds. Sometimes if it gets too big, it has to be excised, but otherwise after pregnancy, those hormones just, leave it alone, and it usually goes away. Gallbladder and liver issues. Gallbladder is often distended because of its decreased muscle tone during pregnancy, has decreased emptying time, and there's some thickening of the bile caused by prolonged retention. Those are just some typical changes during pregnancy. The appendicitis can be difficult to diagnose in pregnancy because the appendix is displaced upward and laterally during pregnancy also. Everything gets moved while you're pregnant. Shows changes in the rectus abdominis muscles during pregnancy. So in A, you see a nice normal pregnant mama, and B, you see that diastasis rectus abdominis in a pregnant woman, so how it's split. I have done fundal checks on moms that have been had these awesome 6-packs, and you can feel how these have split, and it's just crazy to me. I of course have never had a 6-pack of muscles, but just being able to feel how they have split, and then the ones that don't split, trying to get in between there to feel the fundus is very hard. But you get to see all kinds of different things. Let's see here. Talking about some endocrine situations. Prolactin, put out by the anterior pituitary gland, really prepares our breasts for lactation, which, does a wonderful job. When our body starts to make colostrum already anywhere from like 16 to 24 weeks gestation, that our body is already ready in case we would have an early baby delivered. Oxytocin, also by the pituitary, but the posterior pituitary, stimulates uterine contraction, stimulates milk ejection from the breasts. So oxytocin is that natural hormone that does many things for us for labor and delivery. We also have the human chorionic somatotropin hormone, which helps the placenta and acts as a growth hormone, contributes to breast development, decreased maternal metabolism of glucose, increases the amount of fatty acids for metabolic needs. The thyroxine binding globulin for the thyroid, with adequate iodine intake, little or no enlargement of the thyroid. Total T3, T4 levels are slightly increased during pregnancy and usually peak by mid-pregnancy, and by term about 10-15% lower than non-pregnant state. Our parathyroid controls calcium and magnesium metabolism, and our pancreas increases production of insulin to compensate for insulin antagonism caused by the placental hormones. So the effect of insulin antagonists is to decrease tissue sensitivity to insulin or the ability to use insulin. So our pancreas is working too. When we're thinking about cortisol, our adrenal glands are stimulating production of insulin, which is increasing peripheral resistance to insulin. And then those adrenal glands are also stimulating the reabsorption of excess sodium from the renal tubules. So everything's doing a job. So, what time is it? It is question time. So, a number of changes in the integumentary system occurs during pregnancy. What change persists after birth? Would it be epulis, cholasmia? I don't think it would be C because I can't even say that the right way. Or would it be striae gravidarium? Should I sing the Jeopardy song for you? Do 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 do. Okay, I won't go on anymore because I'm probably hurting your ears. If you said A, that's not correct, because the epulis is a red raised nodule on the gum that bleeds easily and does go away after pregnancy. Really a gingival hematoma or hemangioma really gradually enlarges during pregnancy, but does go away on its own after delivery unless it's too big and bad. Cholasmia, or the mask of pregnancy, blotchy brown hyperpigmentation of the skin over the cheeks, nose, and forehead. That's not correct. C, I don't even want to try to say it, but it's really they're spider veins. I would say spider veins because if I can't say a medical term, I'm going to use lay terms. But they are spider veins. They're tiny little star-shaped or branch-like that are slightly raised, and they pulsate at the end of the arterioles. And they're usually found on the neck, thorax, face, and arms, and they often occur as a result of elevated levels of estrogen. And they usually disappear after birth, and we really didn't talk about those. But if you said D, you are correct, my friends. The striae gravidarium, or stretch marks, they do reflect separation within the underlying connective tissue of the skin, and after birth they usually fade, although they never really disappear completely. So that is that, and thank you, and have a wonderful day.